Hello, everybody. This is Dr. Hamid Elmir. I am the host of podcast with Dr. E. At this podcast, I sit with the world's experts in health, education, and community development to talk about current health challenges and ask them to share their experience, knowledge, and insight with all nations across the world so that we can learn from experts across the globe. Today, I have an amazing guest on the show. Dr. Fran Ho is with us today. Welcome, Dr. Fran.
Thank you. I'm excited to be here.
It's a pleasure to have you on the show. Dr. Fran Ho has been a registered nurse for 4 decades on a mission to help people recover from illness. She is passionate about lifelong learning and completed a diploma, bachelor's, and master's degree in nursing and a PhD in health administration. She is equally as passionate about teaching and has been known as the Tell It Like It Is presenter. She is known for excellence by her peers as demonstrated by being awarded the Nurse Excellence Award from Overlook Medical Center in 2006 for developing a 3-day pain research course and trained hundreds of nurses to be resources for better pain management. She has done full day programs across the country on topics of pain management and end of life care and is board certified as an advanced practice nurse in hospice and palliative care. Her book, Pain Medications and You, was published as a guide for patients to better understand how to manage pain. She was awarded the Clinical Practice Award in 2010 and Geriatric Nurse Exemplar Award in 2015 by the American Society of Pain Management Nursing. In 2009, Dr. Ho combined her knowledge, vision, can do attitude, and skills to launch her own practice called Always Think Comfort, which provided pain and palliative care consults at over 30 long term care facilities in New Jersey. Her goal was to provide support to families who are living in the last season of family member life. In 2020, she again received the Nurse Excellence Award in interprofessional collaboration for the work during the COVID pandemic. During the COVID pandemic, she fiercely advocated for IPADS or IPADS, family visits, and aggressive symptom management for those who were dying of the coronavirus. Last year, she established Palliative RX, which provides online courses for patients and families suffering with chronic illness. It's such a pleasure to have you on the show, Dr. Fran.
Thank you. I'm glad to be here.
Dr. Fran, I start with the very personal question, and all my guests are starting with the same answering the same question, and that is very important to me. I'm pretty sure it's very important to yourself, and that is, why do you do what you do, or why palliative care?
Well, it is a personal question and it does have a personal reason. I think mainly I'm a fixer. I've always been a fixer, and we have a broken healthcare system. And our healthcare system is most broken around the area of end of life care. And I realized looking back over my career that I've always cared for the most vulnerable. In the 1980s, when I started, I worked in the intensive care unit, and that's where I learned that just because we can doesn't mean we should. And then in the 90s, I worked in nursing homes, and I realized that we really don't do a good job at taking care of people at end of life. And then in the 2000s, I ran an inpatient pain service at Overlook Hospital in New Jersey, and I learned that we really don't manage pain adequately. The fear of addiction is a real fear, but patients that are dying of cancer shouldn't be worried about whether they're going to get addicted to their opiates when they have less than 6 months to live. So all of these years of working with the most vulnerable, in 2006, my mother became my patient. My mother was 77 years old and she fell and she broke her femur in 10 places. And she was your typical 5-foot Italian. We always say 5 by 5. She was as tall as she was round. And she shattered her femur in 10 places and she never walked again. About a year and a half later, she was having some cardiac issues, and I took her to the doctor, and she was diagnosed with cardiac amyloidosis. And I didn't know what that was, but when I looked at the nurse practitioner in the room and I looked at her face, I knew it was bad. And then the doctor told us that she had less than 6 months to live and that there was nothing he could do, and was ready to let us leave the office with that information. And I said, well, if my mother has less than 6 months to live, I need hospice. I mean, I was using every ounce of energy I had taking care of my mother for the prior year and a half. I had a teenager at home. I was working full time. I had my mother, living with me and living home back and forth to her house. I had a little elevator put in my garage so she could get into the house in the wheelchair. And she had 6 months to live. And 3 months later, she was going to daycare, and she came home from daycare and told me she hadn't urinated. And I said to my father, monitor her overnight. And the next morning he said, no, she didn't urinate. So I called the hospice nurse and I said, she must need a Foley. So the hospice nurse came and put a Foley in. That day, no urine. So I called the doctor and I said, she must need IV Lasix. So that day, Tuesday, I came home from work and I brought IV Lasix and gave it to my mother. Wednesday morning, I called my father and he said, no, really less than a cup in the bag. So Wednesday morning, we went to the hospital. They put my mother in the intensive care unit. They put her on a milrinone drip to try to get her heart to pump, which would get her kidneys to perfuse, which would get her to make urine. And that didn't work. And they wanted to do hemodialysis. My mother was 79 years old. She couldn't walk. And I knew what hemodialysis does to 79-year-olds. I know that was one of those scenarios where just because you can doesn't mean you should. And we talked about it and my mother didn't want it. So the next day, on Thursday, they transferred her to the regular floor. And on Thursday afternoon, she went into a coma. And I knew that she would never wake from that coma. And I knew that I now had a limited time to tell her everything that I wanted to tell her for the past 49 years. So I was talking nonstop for hours until the nurse came in and said, maybe you should give your mother a break and go for coffee. And the next day on Friday at 8:45 at night, 60 hours after I brought my mother to the hospital, she died. And I know that I gave her the best quality of life that she could have in her last 2 years. But I also knew that I needed to fix this system, that this system was broken. And out of that, in 2009, I created my first business, which was Always Think Comfort. And I provided palliative care to patients in nursing homes with a team of 5 other nurse practitioners. And we were at 35 nursing homes in New Jersey, helping people have better quality of life in the last months of their life. And that's why I do what I do. That's my mission for my mom.
Well, thank you for sharing that, Dr. Friend. And these type of personal stories is something that is the motivates people to do it wholeheartedly, whatever they do. And of course, if especially in the healthcare practice or industry, if you know your why, which I'm sure that all healthcare providers know their why, and that is to help people. And of course, when it comes to your own family and your mom, that is it's really painful when you see a member of the family suffering and you can't do much. And the program that you started, we will definitely be hearing more about your practice and everything that you've been doing in the last few decades. And I'm sure that people have heard about hospice and programs and palliative programs, and maybe not enough. So if you want to differentiate, what would be the difference between hospice and palliative care?
That's the question of the decade, because everybody thinks they're the same and they're not the same. There are a lot of similarities between hospice and palliative care, and there's differences between hospice and palliative care. So first, I'm going to talk about the similarities. What's similar is both hospice and palliative care, their goal is to provide aggressive symptom management, to make sure people are comfortable. In both hospice and palliative care, the goal is to talk about advanced care planning. What's coming next? What do they want? What do they worry about? What's their biggest fear? What causes them the most stress so that we can address that? In both hospice and palliative care, it's not just the patient that we're taking care of, it's the patient and the family. Because serious illness is not something that just affects the patient, it's something that affects the family. Studies show that families that watch someone suffer more than the patients themselves are suffering. Just watching your loved one dwindle away to nothing or suffer in pain is more painful for family members sometimes than it is for the patient themselves, who may or may not know exactly what's going on. So we really have to never forget the family, that it's the family and the patient that we take care of. So those are pretty much the similarities. The differences, though, are big. You know, hospice is a program that was designed for people living in their last 6 months of life if the disease runs its normal trajectory. So the problem with that is that many providers were not willing to say years ago that a person had 6 months because they didn't want to be wrong. And what if the person lived a year and they said it was only 6 months? Or what if they said they only had 6 months and then the patients might give up? So doctors really didn't want to prescribe hospice years ago. So they would wait until they were sure the patient was dying, which was generally the last week of their life. And then they'd call hospice in, which was really never a good time because hospice provides so many great services that you really should benefit for over the 6 months. They have a chaplain to help you deal with the spiritual issues around end of life. They have a social worker to help you with, you know, the social issues and the family dynamics, which we all have. You know, they have a nurse to help come and manage the symptoms and a doctor and an aide. So you get a whole team of professionals to help you when you're on hospice and you're in the last 6 months of life. So often as a palliative provider, I'm looking, if I think people have 6 months or less, I want to get hospice in earlier rather than later so they can benefit from all the services. But families always say to me, oh, don't you think it's too soon? Well, no, I don't think it's too soon because I think your family member is going to live 6 months. And if they do, they should get all the services they can. So hospice is something that's meant for people in the last 6 months of their life, and they have to have a serious illness. Palliative can be used at any time during the illness. Palliative can be used at any stage, even when they're getting treatment. Many big cancer facilities will call in palliative early on when the patient's diagnosed, before they start their chemo and their radiation, because they know they're going to have a lot of symptoms as a result of chemo and radiation. They're going to have pain. They're going to be anxious. They might not be able to eat. They might have trouble sleeping. They might be depressed. So you get palliative on board early so that palliative can help with managing these symptoms and managing expectations and helping them know what's to come next. So palliative can be used at any time during a serious illness to help with both the emotional symptoms, the physical symptoms, and the family dynamics, and just help them, you know, walk through the journey.
Great. Thank you. This was really, you know, important to know the difference, especially for the audience. And as you said, it's been a decades-long question.
Yes.
And people were always, you know, I hadn't heard this great, you know, differences and similarities explained this way that you did. Great job on that. And I think you put it very well in that's you know, hospice is the last 6 months, and it's based on what you mentioned. Palliative could be a little more than hospice in many ways, and one of them is that it's not only focusing on physical part of health, but also mental and, you know, spiritual and emotional part of it, which I think it's very important, especially when it comes to patients in their end stages and end stage of life, and it's not easy, not only for the patient but also for the family members, as you mentioned. And there is also a saying in Farsi that is similar to what you mentioned, that it says that when someone's sick or ill in a family, the whole family is suffering. And so, as you mentioned that earlier, that when people who are watching, family members, another, someone is suffering from a disease or illness in the family, they are suffering more than the patient.
That
And
is
that,
true.
that is very true. Um, So what just a follow-up question on this, what would be the settings in terms of palliative and hospice? You explained that. So does it require the same kind of settings? Does it require a larger area?
So a lot of people think when they call palliative care, they think they're going to get services similar to hospice because they think
Mhm,
it's the same. And they're like, well, when does the aid start coming? Palliative is a consultant service. So in the hospital, I am on a palliative service. So we have chaplain support, we have social work support, we have physician support. And then when the patient goes home, they would follow up with the palliative care provider once a month, like they would with their cardiologist or their, medical doctor, just for follow up. We're not sending people to the house to take care of them, but we're there to manage what's going on with them.
mhm,
So, whenever you have a serious illness, whether it's heart failure, COPD, dementia, cancer, end stage liver failure, end stage kidney failure, and you're having symptoms and things are going on, or you're having frequent hospitalizations and you're not sure what's happening, or you're having symptoms that really aren't well controlled,
mhm,
or any of those scenarios would be good to call and ask for a palliative care consult. Most of the hospitals, I think the numbers are 90% of the hospitals at this point have palliative care services. They're all constructed a little differently.
mhm,
But most hospitals today, no matter what the size, have a palliative service. So if you're in the hospital, you can ask to see the palliative service, and then you can get an idea of what kind of things they provide and how they can help you. And if you're at home, you can ask your medical doctor that you're going to, could they refer you to a palliative service? Some of the hospice programs have palliative services. Most of the hospitals, some of them have outpatient palliative services that they can refer you to. So
mhm.
you could call your local hospital and say, do you offer any palliative services, and see how they can help you. So that's those, I think, would be some examples of when it might be time to
Okay.
call and how to get them.
Yeah, great, great. So who would be appropriate for palliative care? You kind of alluded in your previous discussion, but maybe you can go deeper into that.
So if you've been had a cancer diagnosis and you're currently getting chemotherapy, but you don't want to stop chemotherapy, but the pain is just uncontrolled. I have patients come to the hospital and they tell me they set an alarm clock for the middle of the night to take their pain medicine. Otherwise, they wake up in the morning with excruciating pain. So that might be a good time to say we need a palliative care team who can focus on symptom management. If you have a mother or a family member with dementia and they're not eating and they're losing weight and they're thinking about putting in a feeding tube and you're not sure whether that's the right thing, and you want to talk to somebody who can be a little more objective and look at the whole picture with you. The American Geriatric Society does not recommend putting feeding tubes in patients that have end stage dementia. The studies show that people don't live longer with feeding tubes or without feeding tubes when they have dementia, and people don't realize the complications that can arise from feeding tubes. Again, we're back to the scenario of just because we can doesn't mean we should. Just because we can put a tube in somebody doesn't mean we should. I remember the first time I read a note from a gastroenterologist who was called to put in a feeding tube, and he wrote he did not think a feeding tube was appropriate for a patient had stage 4 cancer who was in her last 6 months of life. He didn't think the feeding tube was appropriate. I wanted to kiss the piece of paper. I was so excited that
Mm.
finally somebody said there are times that things aren't appropriate, and that was one of them. So if you're trying to make a decision, should you have more chemo? Should you go with surgery? Should you just take a more palliative route and stop with the aggressive management? That would be a good time to call palliative.
Mhm. Great. Thank you for that description. And how does palliative care benefit the individuals?
Well, they did a study last year. They looked at lung cancer patients. They looked at lung cancer patients that had the same kind of cancer. And they looked at patients that received aggressive chemotherapy and patients that were on a palliative program and not getting chemotherapy. And they found that the patients on the palliative program actually lived longer. And, you know, one of the things you have to think about is the more things we do to a person, the
Right.
more risk you have something can go wrong. And I'll give you a really good example. I had an older woman in the hospital. She was in her 80s and she had chronic kidney urinary tract infections because she had a stone. And she also had something going on in her stomach with her bowel, and she needed to have her bowel fixed. And she also had a big mass on her face that she wanted to have removed. So her son said, we got to get these 3 things done. Once we fix these 3 things, my mother will be fine. When I asked the mother what was most important to her, she told me she wanted to live long enough to be at her grandson's wedding, or her great grandson or her grandson, whatever it was. And that wedding was happening in about 3 or 4 months. Now, this woman would have lived for 3 or 4 months. She had already had her belly fixed, and now she had the kidney issue. And she kept getting chronic infections because of the kidney issue. And I said, well, we could just keep her on chronic antibiotics and just try to keep the kidney infection at bay. Maybe we could take a less aggressive approach rather than take a more aggressive approach. They wanted to bring her in and do smash the kidney stone and, you know, get rid of it. And the family was like, no, we want this procedure done. And she died while they did the procedure. She died very shortly after, within 24 hours. And it's just an example of, we do all these things sometimes, and sometimes we should just leave them alone. And if we're really looking at a quality of life and we want our life to be as full as it can be, and we want to be symptom free, and we want to interact with our family, and we want to be out of the hospital, you know, especially now with COVID, so many hospitals are restricting visiting. You know, my hospital, we have no visitors in the hospital, you know, and if you've got a patient that's got an end stage disease, you know, I'm saying to the family, if she's got a couple of weeks left, do you want her to be in the hospital where you guys can't even see her and be with her in her last weeks of life? Or do you want her to be home with you and stop these IV fluids and all of these things that we're doing? You know, so again, we're back to what is most important to the family. What is it that they want? What is it that will make them feel happy and give them closure and give them the ability to just, you know, do what they need to do as a family? So that patient that I was just talking about, she's going home on Monday. She's going home tomorrow because she wants to be with her family. And she's been in the hospital for 3 weeks, and all she keeps doing is getting more and more complications. So let's just send her home and allow her to be. She has a 9-year-old son. Let's just let her be with him.
Yeah, definitely. Those are really the hard times when a family or a healthcare provider, a physician, nurse, and other healthcare providers make a decision what to do, and which is, you know, at the end of the day, beneficial and more important for and helpful and useful for the patients, right? And that's the ultimate goal for all of us as healthcare providers. It's also, of course, the families. They want their loved ones to live a better life with better quality, either if it's at the hospital or it's in the palliative care, hospice, or at home.
Sometimes I say to families, you know, it's like getting on a train when you come to the hospital. You get on a train and there's no stop. You know, it just keeps going. You know, let's do this test. Let's give this antibiotic. Let's do this procedure. Let's go to surgery. Let's do this next procedure. You know, let's do this next CAT scan. Let's find this. You know, and I always tell people, you know, if you're not going to do anything with the results that you have from a diagnostic test, why are you doing it? If your 90-year-old mother, you know, is having brain issues and she's demented, and now you have to send her for an MRI or a CAT scan where she has to lay still and she's already confused, and you're now putting her in a CAT scan or an MRI machine and she doesn't know where she is and she won't lay still, and you're going to find out that she has a brain tumor that you're not going to do anything about anyway. Why are we going for an MRI? Why are we doing a procedure if we're not going to do anything with the results? And sometimes people need to know. People need to know for their family. Well, I need my family history. Do we have a cancer history? You know, but if it's a patient who's had cancer before and you're just looking for spread, and the patient is old or sick or frail and you're not going to do anything anyway with those results, then you shouldn't be doing the test, because you're not going to do anything with the results. Now we give a dye, we do a test where we give a dye and then we shut the kidneys down. Now the kidneys don't work because we just gave dye, because we did a test that we're not going to do anything with the results with anyway. So we really have to think about, when we do all these tests and procedures, are they really going to help us in the end, or may they make things worse?
Yeah, I'm pretty sure that the healthcare providers, when they make such decisions at the hospital level, or even in the healthcare facility, people think and consider all different aspects of it, from medical ethics point of view to what is good for the patient, what is what the family wants, and also to avoid all these unnecessary kind of testings, as you just mentioned, which unfortunately maybe it happens sometimes, but most of the time, of course, all healthcare providers, when we all just sworn in what to do, and we are always putting patients first, and of course, if it is necessary and needed, it should be done. However, from a public health perspective, I've heard it many times from public health professionals that sometimes there are some unnecessary paperwork or some unnecessary tests that being done that could be provided and avoided. And I don't remember exactly who was the speaker, but one of the speakers, she was talking about about the that America is rich and there is enough money here in the US, but it's not going the right way when it comes to health issues. And I think we can do all together, work hard to make sure that everything is taken care of and it goes the right way, and it's, people have access to quality health. And at the end of the day, as I mentioned earlier, that patients and their families are happy with the care that they receive. And you are actually the first nurse on my show, and I've started this this show during the COVID, in the wake of COVID-19, and I started with physicians who are directly in the first line treating COVID patients, and of course other physicians who are working in public health, as well as I had only maybe one clinical psychologist on the show, and you're the very first nurse on the show, which I really appreciate your time. And I think healthcare providers all in general are need to be appreciated, and with their hard work, especially someone like yourself who has dedicated his life and more than 4 decades in taking care of patients. And you, as I mentioned in your bio, starting from something very basic steps, and then you went all the way to a PhD and did a PhD in health administration, and your master's and everything. That I'm pretty sure that the time you did it, probably it was not that common, at least for nurses.
Exactly. When I graduated nursing school, it was 1980, and I wanted to teach nursing. But you needed a bachelor's, and I just had a diploma. So I went right back for the bachelor's, but it took 4 years. And by the time I got it, you needed a master's. So then I went right back, because there were so many people in my bachelor's program that had kids and were going to school and working. And I'm like, I got to do this before I have kids. So then I went right back for my master's. But yeah, I consider myself to be a visionary. I had a nursing practice in 2009 when, just when nurses were starting to go out there and hang their shingle and have their own practice and bill the insurance companies, Now, I'm the only nurse in the hospital that is not a hospital employee, that doesn't work for a hospital doctor, that has her own practice and sees patients on the medical staff as a consultant. I know there's not many nurse practitioners out there, or advanced practice nurses, that are doing, online courses for families that are live, because I looked it up to see who else is doing these courses, so that you can go online and get, interact live with a clinician who can give you, information and clarity on what's going on with your diagnosis. So I consider myself to, have always been a little bit ahead of the curve. So I'm glad I'm your first nurse. Hopefully I'm not
Yeah.
going to be your last.
And no, hopefully not the last one, and definitely not the last one. And congratulations again. You are doing great, and you've been, this is rewarding what you do, and especially during this hard times during this pandemic. And I'm sure that you've helped a lot of people. You saved a lot of lives, and I really appreciate that. And thank you for all what you do. Going to the very last question, and it's more of a professional one. As I said, like, you are dealing directly with palliative care as a consultant, and also you have your practice, you have your online programs that you recently started, and you are also, working at a hospital. You've been working at a hospital for a while, and maybe some of the health care providers and professionals who are not familiar with the where to find the resources. Maybe you can tell us and the audience, what are some of the resources for patients for palliative care?
So I think that, one of the big trends that we would like to see happen is that more providers are addressing goals of care in the office. The problem there is that they just don't have a lot of time. Now we're going to computerized charting, so that makes less time. Now we've got limited time. Now we've got virtual visits. So it's not super easy to have, and this is not a 5-minute conversation. By the way, what do you want to do at end of life if your heart stops? This is not that kind of conversation. This is a 20-minute conversation. But there are resources, people should look at, advanced directives. What are, does the patient have an advanced directive? Offices should have copies of advanced directives so they could give them to patients. There's another thing called the 5 wishes. I have this one. This one's in Spanish, but it's also in English. And this kind of is something good that you can give to families. This comes from Aging with Dignity. They'll send them to you for free. In English, Spanish, they have them in many languages. You can just hand it to the patient. It's a guide for them to think about, who should be their healthcare proxy. What would they want if this should happen or that should happen? The form, all of the different states have different forms. In New Jersey, we have a POLST form, Practitioner Orders for Life-Sustaining Treatment. In New York, it's MOLST, Medical Orders for Life-Sustaining Treatment. You should know what the ones are in your state, and and do complete that with a patient once they've had the opportunity to look. CAPC is a good organization for professionals to go to. CAPC, the Center for the Advancement of Palliative Care.org. Diane Meyer, Dr. Meyer is one of the doctors who runs that. She's an amazing, amazing individual who does some really excellent talks, and they keep a lot of the data on, how many hospitals have programs, what those programs consist of, all data on everything. They have COVID resources, free COVID resources. It's really a great informational website for the professionals.
Okay, great. Thank you for mentioning that. And the advanced directives is one of the important parts. Actually, when I was reading about it, it started in the 60s, sometime like 1960s. So it's been like 60 years. And of course, the 5 wishes that you just mentioned. Some of these resources are, very helpful. Of course, all of them are very helpful, but they healthcare providers need to know about it, and pretty sure that the health systems they know about it and they have it there, so so they can use. And the we're to the end of this show. I just wanted to ask you if you have any final thoughts you wanted to share? Also, how can the audience learn more about your work and to get connected with you if you have any? You recently also started, online programs and stuff. So could you just
So
share
yeah,
that
to
with
find
the
me,
audience?
you can go to my website. It's www.palliativerx.net. And you can learn all about the courses that we give. They're 5-week online courses. They're interactive. A lot of cool things happen. A lot of strategies and tips that you can learn how to manage your symptoms, how to deal with your illness. So you can check us out at palliativerx.net. And just being aware, just always thinking about, you know, is this person appropriate for palliative care? Do they need some extra support? Is a family struggling with, whatever's going on at home, and maybe somebody who's not, um, dealing with their medical diagnosis, who could look at all of those outliers, as you mentioned in the beginning, the spiritual piece, the psychosocial piece, the educational piece, the physical piece, the emotional piece. I mean, there's a lot going on when somebody's got a serious illness. And, face it, the primary team doesn't always have the time and the resources to deal with all of that. And we're just an added layer of support to help them help their patients. And we can work together really nicely.
Okay. Thank you so much again, Dr. Fran. It's been a pleasure to have you on the show, and best of luck with all you do.
Thank you. You too. It was great. Great to be here and share my insights. Thank you so much.
You're very welcome. And dear audience, for more shows like this, please stay tuned with Dr. E podcast. Have a great day and see you in the next podcast.